Morning, Sergey, and I guess that's Uzo.
Good morning, Dr. Pass.
Wait just a few moments. We'll give it one more minute, I think. Okay, why don't we get going then? Okay, excuse me. As predicted, this is an angiogram, old school, however, used with a very ultra-low fluoro technique of the RAO during an EP study. So I'm going to ask, let's see, why don't we ask Dr. Obiaka to point out which catheters are which. So Uzo, I'm pointing now to one catheter, which is this catheter. Where's this going?
So that looks like maybe the His catheter.
This is the His catheter, you think? I think that is not correct. Where is this? All right, well, let's start with this then. Where is this catheter?
So that looks like the CS catheter.
Right, so it has 10 electrodes for 5 pairs, a so-called decapolar catheter. Some people will put this catheter, in this particular example, is placed from above, presumably from the right IJ, but it could also be placed with a deflectable catheter from the groin. Dr. Love will often use an octopolar catheter for this, but bottom line is a multiple electrode catheter from that goes in the coronary sinus. So is the His catheter typically above or below the level of the coronary sinus?
It's usually below the level of the coronary sinus.
No, it's usually above, right? Above. Remember that the His catheter, of course, is recording the His bundle, which is immediately adjacent to the AV node.
AV node,
What are the borders of the triangle of Koch?
The mouth of the coronary sinus, the tendon of Toredo, and the tricuspid valve septal attachment.
Right. So is the His catheter at the top of the triangle of Koch or at the bottom of the triangle of Koch?
At the bottom of the triangle of Koch.
No, it's at the top, right? It's up near the His, right? We don't want to be anywhere, right? You know how when we're ablating like a like say AV node reentry, we don't want to
The,
be anywhere near this catheter, right?
the
And so
coronary sinus catheter is below. Sorry, on my sheet I'd put it as CS. The CS is below this
always the CS
triangle.
is going to be, most cases, the coronary sinus with normal structural heart will be lower than, and of course, if we were looking at the LAO view, we would see that this is also posterior to the position of the His catheter. And so, so this catheter seems very unlikely to be the His catheter, since it is obviously quite
Yeah.
inferior to the level of the coronary sinus catheter. So what is this catheter, do you think?
It looks a little bit low for my transeptal, but I'm wondering because
It could theoretically be transeptal and be sitting in the left ventricle, but it's in the right ventricle.
oh, okay. So my RV catheter.
Right. So we have, here's the RV catheter coming from the IVC. This is the His catheter. And the His catheter typically has a minimum of 4 electrodes, but a lot of laboratories will use a hexapolar catheter with 6 electrodes. But what we do in our particular lab is we record from the distal electrode to the second electrode, then we record from the second to the third electrode, and then from the third to the fourth, so that we project on the screen 3 His electrogram signals, but you could put multiple. Some labs will even put a decapolar up and want to see a His on all of the leads, and it can take quite some time to get it in perfect position for that. So yes, the triangle of Koch, remember that the mouth of the CS is going to be somewhere around here where I'm pointing. And so you would always expect that the His catheter is superior to that in the vast majority of cases. And in this case, we would say that the triangle of Koch is fairly small because it looks like the distance between the posterior septal region, which is marked by the mouth of the coronary sinus, and the anterior septal region, which is marked by the His catheter, is pretty small. Now, on the lateral view, it may be that one is quite anterior to the other, but the bottom line is that in a supero-infero direction, this is a fairly small triangle of Koch. And this patient actually did have AV nodal reentry. And so the first applications that were actually made at or even below the level of the mouth of the coronary sinus. And these did result in junctional acceleration, consistent with being near to the slow pathway. Okay. All right, let's move on. Okay, so this is a download from a patient who has a defibrillator. And just to sort of orient everybody, this is what we will see typically in a Medtronic device. So when we do these downloads, or patients do downloads, remote downloads, the first thing that they usually submit, and again, this is all automated, but the first thing that Medtronic will record is what they refer to as the presenting electrogram, meaning that they're just basically giving us an example of the rhythm as it is at the time that the patient performed the check, okay, or that the check was performed. So we're looking here at the electrogram from the atrial tip to ring. So this is basically the atrial electrogram. So we see a nice large atrial electrogram, and it's telling us that every millimeter is 1 millivolt. And so we see that the atrial electrogram in this particular patient is actually quite large, right? It's probably more than 10 millivolts. It's very unusual, but great. It's nice to have a very large electrogram. Then we are, excuse me, recording an electrogram from the can. Can usually refers to the device itself and the coil on the defibrillator lead. So this is a very large distance. So presumably this should be a ventricular electrogram, okay? Then it's also recording the RV tip to ring. So this is the actual true electrogram that's recorded at the tip of the defibrillator lead, the so-called bipole at the ends. And interestingly, this is the smallest electrogram. Again, the scale is 1 millivolt. So this is a very small ventricular electrogram. And then this is another electrogram that they're giving us, which is from the can to the superior vena cava. So presumably this lead has both a SVC coil, which some leads do, and a coil in the heart. generally speaking, in the present era, we try not to put leads that have SVC coils in. The theoretical benefit of an SVC coil is it may lower the defibrillation threshold in a patient, but the reason we generally shy away from them is because it's another area to adhere to the vein, which could make future extractions more difficult. And there isn't really a lot of evidence that having an SVC coil makes a very large difference in defibrillation threshold. So, and then finally at the bottom, excuse me, we have a marker channel where it's essentially telling us what is the defibrillator seeing. So we see it saying A sense, V sense. So this is presumably the A, and then V sense, and then it's giving us the number of milliseconds between that beat and the next beat, A sense, V sense. So, and so on and so forth. So the question I'm asking is, what is this rhythm? And I'm going to ask this of Dr. Bonsall. Perna Bonsall, because I know 3 doctors named Bonsall.
Good morning, Dr. Bass. Can you hear me?
Yes, can hear you very well.
Okay. So it looks like initially we are E sensing and V sensing. And then in the middle, I mean, not really middle, but as we progress further.
Referring to this beat here?
Yes. So then there is no A sense, there's only V sense over there. And then again, the A sensed after the V, and then again there is a V sense. And then there is again A sense, but it's not conducted. So it waits. And then again, it A senses and V paces. Earlier, we were just A sensing, V sensing, but now we are not conducting.
So what do you think is happening in these 2 beats here?
That there is like PVC, maybe it's sensing.
That's right.
It's V sensing, but not basic.
Right. So this is an example of what is probably a ventricular couplet or 2 PVCs in a row. Now, we know that because we have V's before A's, right? And also, if you look at the electrogram in all 3 leads, and this is one of the nice things about having different electrograms to look at, I think you would agree that these 2 beats have a different morphology than these presumably sinus beats, right? If you look in 3 leads.
I agree.
So, thank you. So this is an example of a patient who is having PVCs in sinus rhythm. And, you know, just interesting that the patient has such a burden of PVCs that we actually are seeing it in the presenting electrogram. Also, interestingly, if you look at the bottom of the tracing, what's going on here?
So we're A sensing, V sensing. And then for some time, we don't sense the atria, so the ventricles start pacing. So the defibrillator starts pacing the ventricle.
Okay.
So,
right, that's correct. So can you tell me, what do you believe is the lower rate limit of this pacemaker set at, based on that?
it should be, so here it's sensing when it's 1, 2, 3, 1200. So 1200, 60,000 divided by 1200. 50. So it's 50.
That's right. Because we see that the device has properly sensed this this ventricular event, which is sinus rhythm just before. And then for some reason there's a pause and there's a paced complex. So a lot of information just from the presenting electrogram of a couple of seconds. Okay.
Dr. Bass, I have a question. So on the first, the A tip to the A ring, just before the PVC, actually just seems to happen in time with the PVC on the first strip, there's sort of like a deflection.
Yes.
That seems to be a P wave.
Are you referring to this here?
Yes.
Yes, that's very astute, Uzo. What you're looking at here is the far field ventricular electrogram. So let's look at the sinus beat at the start. So I think you would agree that this is the atrial electrogram from sinus. But what's interesting is that you see that there is this deflection or this small little signal that looks almost like a P wave, as you described it, that is on time with the QRS. Okay. The reason that we see this is because it is likely that the atrial lead has been inserted into the atrial appendage, the right atrial appendage, which is the most common location that atrial pacing wires are placed transvenous. And so because the atrial appendage typically lies externally, it's sort of flopping over and extending onto the surface of the RV, it is not uncommon to see a small ventricular electrogram on the atrial lead as well. Thankfully, however, I think you would agree that the atrial electrogram is far greater in size than the ventricular electrogram. And in this particular case, the atrial electrogram is quite gigantic for an atrial electrogram. It's about 10 millivolts. And so it would be very easy to program this device so that it would see the atrial electrogram, but ignore any small far field ventricular electrogram. Okay. The other interesting aspect here is that I'm not sure, but there's a suspicion here that this could be ventriculoatrial Wenckebach, right? So if we see here's a ventricular beat followed by an atrial beat, and then a ventricular beat followed by an atrial beat, and these two beats are a little bit, the VA interval is lengthening. So this could be an example of ventriculoatrial Wenckebach as well. Okay.
Thank you.
Thank you. Okay. Let me see here. We have, I guess Dr. Barris is away today. So let me ask Dr. Kung. This is an ECG that was obtained on a pre-cath patient, and the computer says that the patient is in sinus rhythm with first-degree heart block. Do you agree with this assessment?
It actually looks like the PR interval is very short.
Mm-hmm.
I'm trying to look for a delta, so I'm suspicious about a WPW.
Mm-hmm.
There's not such a clear delta wave, but given the short PR, can we still call this WPW, Dr. Pass?
Well, I mean, I would agree with you 100%. There is a short PR, but and whenever you see a short PR, of course, we would always at least be concerned about the possibility of WPW. However, I think you would agree that we have fairly nice Q waves in a lot of the leads, particularly in the left lateral, right? In V6, we see a very nice QRS. So usually people who have WPW have a slurring, right, between the P wave and the QRS. So I guess my first question is this sinus rhythm?
Oh, that's a good question. So if I look at the P wave, no, into an AVF, the P is actually down. So this is not sinus rhythm.
Right. So this is what we would refer to as a low atrial rhythm, because it's sort of negative in the inferior leads. So presumably it is coming from the area of the inferior leads or the inferior portion of the right atrium and moving in the opposite direction. So the reason that the PR interval is likely short is because probably the atrium is starting its depolarization very close to the area of the AV node. Okay, does that make sense?
Yes, that makes sense.
Yeah. So this is not AV block, first degree AV block, and it's not even sinus rhythm. This is a low atrial or a non-sinus atrial rhythm at a rate of 84 beats per minute. Okay. So just thought, never trust your computer. Okay. A lot of EKG tracings today. So let's see if Dr. Alwalia, you are reading this Holter or Zio, and this is the tracing that you see. Do you have how would you describe this? You have to interpret it. You are working in a very remote area where There is not an electrophysiologist to interpret this, so you must interpret it. So how would you describe this in your report?
Let me see. So the first two beats look sinus, the third beat looks PAC, and then sinus. So I would read it as, and I'm seeing if there's any relation with how frequently the PACs are coming.
Mhm.
And at least in this strip, it's every third beat that I feel is a PAC.
Yeah.
So I would say I just have one lead, but I'm going to presume this is sinus, the P wave axis based on this. So normal sinus rhythm with PACs in trigeminy pattern.
Right. Right. So you could call this that or atrial trigeminy, or
Atrial trigeminy, yeah.
as long as you describe it properly, it doesn't really matter. If you want to say it's sinus rhythm with a PAC every third beat, that's fine too. There's no right answer. There's only a lot of wrong answers. So, right. Okay, good. All right. This is, I saw this on the weekend. This is Dr. Mohan, who's an electrophysiologist out in Kentucky, I believe. And he posted this 11-year-old male with tachycardia on beta blocker for years. When forgets his dose, has breakthrough. Tachycardia was only captured on a vent monitor, a narrow QRS regular tachycardia, 210 beats per minute. Unable to see the P to know if it's a short RP or a long RP, baseline normal sinus rhythm, and no pre-excitation. Presents for a study. So, since we know that Dr. Ahluwalia is on the call, we'll call her back and ask her, first of all, do you agree, first of all, that there is not pre-excitation? And, you know, I think this is one of the main reasons I'm showing you this case is because I just want you to get used to seeing the electrograms projected in different ways, because when you take your board examination, they may not display it the way Robert Pass and Barry Love like to display it. But I think you would, you know, even the colors in this case are different, but usually they'll just do it in black and white. So it's always, again, when you're looking at these tracings, always important to look at the legend on the left-hand side. They're not actually very different than in their way that they're displaying it than the way that we display it, but it is important to review it. So in this laboratory, we have 5 surface ECG leads. In our lab, we usually display only 3. They have a distal and proximal ablation, just like we do. They have 3 pairs of the His, and they're going from distal to proximal, similar to the way we do, but they're displaying them in green. We usually use yellow, but again, that's a completely and totally arbitrary decision. And then there's a decapolar coronary sinus catheter, again, going from proximal to distal. But again, this is very important. Some labs may display it the opposite direction, from distal to proximal. So you always have to check. This is a little misleading because it doesn't really say if 910 is proximal or distal, but I'm telling you, this is proximal distal. And then in this laboratory, they're showing us 2 RV electrodes, presumably the distal and the proximal electrodes of the RV. So now that we have gone through that, is this patient, Dr. Mohan says the patient is not pre-excited. Do you agree with that statement? I should mention he's a good electrophysiologist.
All right, so I will agree.
Okay. How do we know that though? How do we agree Sean is right, but how? But tell me why he's right.
Yeah. So based on first the surface, I don't think I see pre-excitation on those leads.
Very good point. That is always where you should start when you're looking at these tracings. I agree with you 100%. The surface does not appear pre-excited. So you pretty much have about 100% chance of being right now. But now I want you to tell me from the intracardiac if the intracardiac leads confirm that that impression of the surface.
Right. So all the V's seem to be on time in the coronary sinus pathways. I cannot differentiate as one is earlier than the other.
What does that tell you, by the way?
So it just tells you where your pathway can be in terms of the normal conduction system. You would see proximal first and then distal, versus if you see distal first, then you're concerned about the left accessory pathway.
Right, but the coronary sinus doesn't tell us a lot about right-sided pathways, right? So the point I'm trying to make is simply that if the coronary sinus pattern is normal, you're absolutely right that it rules out or makes it much, much less likely that there is a left-sided pathway. But it doesn't actually tell us about the right side, but that is true. It has essentially more or less ruled out an antegrade conducting WPW left-sided pathway. Okay, please continue. So still consistent with the absence of WPW. So far, Dr. Mohan still is right.
Right. What else can I say from this? And also his, all, I mean, it's hard, but I think they're all on time. I don't see.
So what are the normal His intervals? What's a normal AH and a normal HV roughly?
Yeah, you're right. So I don't see, I see that really little thing is probably the A on the His. It's not yet.
This is actually the His, actually.
Oh, that's the His. Okay.
And there isn't really this, with no offense intended towards Dr. Mohan, not the best His I've ever seen in anybody, because really you would like to see an A, an H, and a V. And in this case, we see mostly just a H and a V and not very much of an A.
Right.
But presumably there's an A somewhere in here. Maybe this little deflection is an A. But I guess my biggest question is, what happens to the HV interval when people are pre-excited?
Very short.
It's very short. And in this case,
so there's reasonable HV.
Right, exactly. Exactly. So there is no V in. So to measure the HV interval, we measured from the onset of the His to the onset of the ventricular electrogram in any lead. See if it's any of them are early. And I think it's hard to say because I'm just showing it to you on a screen and you don't have calipers like we do in the EP laboratory. But I think you would agree that there's a lot of space between this His and the ventricular electrogram on the His. So presumably this is not a pre-excited patient because the HV interval is normal. What is the normal HV interval again?
50?
35 to 50.
30 to 50.
Okay, so this looks, I can just tell you, having looked at a million of these, this is definitely in the 35 to 50 millisecond range. Okay, so this is not pre-excited. So we agree with Dr. Mohan. Now, Dr. Mohan does atrial extrastimulus testing, and here is a premature beat at cycle length at 600, 290. Here's that extra stimulus that he's putting in. He's pacing from the coronary sinus in this case, and then some tachycardia starts. So do you have any thoughts on the mechanism of the tachycardia, Dr. Luwali?
So let's see. In tachycardia beats, the coronary sinus, I would say that the proximal seems to be the earliest.
And what does that, I agree with you 100%. What does that tell you?
So it's like a concentric pathway.
That's right. It's concentric. It's a concentric pattern, right? So, and we don't really have a very good A in the His, unfortunately.
Right, to see where, yeah.
But what you can say, of course, is you don't see anything in the His that is after this A. So probably the A is
on the V.
in here. Yeah. Also, notice that the ablation catheter, which is presumably in the right atrium, those atrial electrograms are quite a bit later
Right.
in the Hess.
Mm-hmm.
Now, what is this RP interval, you think? I mean, you can just use this atrial electrogram. Is this a short or a long RP interval?
Short.
Very short.
Right.
Also, what do you think about this AH interval here?
If that's very,
Here's the little His. I'm making this up, but the His is
very long.
it's long. So what's probably happening here is that we're putting a PAC in.
Mm-hmm.
We're blocking in the fast pathway. We're going down the slow pathway.
Mm-hmm.
We're re-entering up the fast pathway, going down the slow pathway, re-entering up the fast pathway, down the slow pathway, and so on and so forth. So what is the likely diagnosis?
AVNRT.
Right. This looks like typical AVNRT.
Mm-hmm.
Now, at the time that I put this together, Dr. Mohan promised more tracings from this case each day. So if you're interested, you can go look on Twitter to Sean Mohan and see the rest of the case. Okay, thank you, Dr. Mohan, for this interesting tracing. Okay, this is a text message that I received from a cardiology fellow. Hello, Dr. Past. As a baby in NICU, 9 days old, X33 weeker, who just had an episode of SVT with a heart rate in 300s. It broke with adenosine times 2 doses. EKG is sinus rhythm without pre-excitation. I'll send you the beginning and end of SVT. Baby is undergoing a sepsis workup and is NPO, but the team isn't opposed to enteral propranolol via NG if we want. These were the tracings that were sent to me by the excellent cardiology fellow. And I'm going to ask Dr. Sergey Babia, back from a prolonged vacation, if he can share with us his insights into what he believes is the most likely mechanism and how he would treat it.
Good morning.
Good morning.
I see a narrow complex tachycardia, as mentioned, with a heart rate of about 300 per minute. That abruptly started and abruptly ended with adenosine, which I believe the mechanism would be reentrant. In a 9-day-old baby, I would say that it's most likely an ORT.
That's correct. It is most likely ORT. What else could this be, however?
Well, it also could be an AVNRT.
That's right. It could be AVNRT. About 20 to 30% of neonatal SVT is actually AVNRT. Is there anything here that would make you feel good? So the fellow who sent this tracing wrote to us that ECG is a sinus rhythm without any pre-excitation. Is there anything on this tracing when adenosine was given that would confirm for you this observation of the fellow, that this is not WPW?
Well, I see that the PR is not short, and
That's
I
right.
don't see any. Well, I can't probably say anything about the delta waves when they tally, but the PR is doesn't look short.
That's right. And the important point I'm trying to make here is when you give adenosine and you terminate tachycardia, if you have WPW, typically the first couple of beats after termination will have very significant pre-excitation because you've blocked the AV node. So the first sinus beats that come back will often be very wide QRS with a short PR interval. And then sometimes as the adenosine wears off, you will no longer see pre-excitation. So the fact that we do not see any pre-excited beats immediately, excuse me, after termination of SVT is certainly highly suggestive of the absence of WPW in this patient. So they said that you can use the gut in this patient, but you're not comfortable with it because you are a former neonatologist. You're worried about neck. The patient is NPO. So if you can't use the gut, how could you treat this patient? What are your options?
Amiodarone would be one of the options.
Okay, so yes, you could give amiodarone. The downside of amio in this former 33-weeker in the NICU?
Well, we know that amiodarone has a risk of cardiovascular collapse.
Right, which happens about
5%.
About 5%, right? What else? Any other risks of amio in general in terms of its administration?
It has a very long half-life.
It does, although IV amio not as long.
Oh, you mean the sclerosing of the
Yeah, it can cause
veins?
sclerosing of veins. So you would really only do it if you normally in a non-emergent situation, if you had some kind of central access. Although again, it can be given peripherally, but you have to be very careful because of its sclerosing ability. And I have seen 1 or 2 patients develop small chemical burns from it. Okay, amio is a reasonable suggestion. Any other options?
How about Fleckinite or Procainamide?
Well, Fleckinite doesn't really come as an IV solution in the United States of America, so that's not an option. Procainamide would be a good option. You could put the patient on procainamide and just control the patient in that manner, with the idea that when the gut is usable, we could transition to another agent like a beta blocker. That's not unreasonable. You could also use esmolol. Some electrophysiologists love esmolol. That could be used to temporize. So what do you think about, say, verapamil in this case?
We don't want this option in newborns.
That's right, because it has been shown in some very old data to potentially cause cardiovascular collapse. So we would not usually use verapamil. That would be contraindicated, considered to be malpractice. So I wouldn't do that. Not that I'm a lawyer, but probably that's what a lawyer might say. Okay, so the other option, by the way, is if somebody is in the NICU and is being observed for multiple other reasons, another option is to not treat it and to observe it and just observe the pattern. In other words, if I would probably treat this patient prior to going home. However, if the patient is going to be there for another week or 2 on telemetry, it's possible there won't be another episode until the time that the gut is usable. So you don't absolutely have to treat this urgently either, if you're going to be in an ICU monitored setting. Okay, this is another tracing that was sent to me in a post-op arterial switch patient for DTGA. And I guess I would ask, what do you believe is the diagnosis and how might one treat this? I'm going to go to Dr. Uzoma Obiaka of Alabama for her thoughts on this.
So where we see the green strip, we see that there's a difference. It seems like that's actually just before that seems to be the onset of the tachycardia. Dr. Paz, how old is this patient?
This patient, well, the patient had an arterial switch operation.
Oh, arterial switch, sorry. So it's
you can guess
a newborn. Yeah, I can guess. It will not be a 4-year-old.
Week or 2 of life, yes.
Yes. Yeah, so it's a
What
newborn.
is, by the way, since you asked this question, what is the believed to be the optimal time of life to have an arterial switch operation if you have detransposition?
Some studies say day 3, day 4, but
right.
Generally we stay up until at least the first 7 to 10 days of life.
That's right. There are some studies, mostly out of Colombia and a few other places, suggesting that earlier is better, and that actually the Colombia data suggests like for every day after the 3rd or 4th day, there's certain percentage increased morbidity and mortality. I don't know if that's been confirmed, but that is a belief by some.
Yeah. So looking at the tachycardia strip, I see P waves for every QRS, and they're before the QRSs. But looking at the P wave on this side versus the P wave just before it started, it looks a little bit different in morphology. So I'm tempted to think that this might be some sort of EAT.
Right. So I think the reason I wanted to show this is twofold. First of all, to show you how difficult it is to make an assessment of arrhythmia from a tracing of this nature.
I haven't finished, Dr. Path.
Yes, go ahead.
I was also going to say that I also, I mean, it looks different, but then it could also be a sinus tachycardia and it's hard to tell. So that would also be on my differential as well.
I agree with that. Very good. Excellent. Get 100% credit for that answer. But I think, though, it is pretty clear that there appears to be a relatively sudden onset of tachycardia. We don't actually have the rate, but it's probably in the range of about 200 beats per minute. And I agree with you. The unusual, so normally if we see a sudden onset tachycardia like this, we might think of a reentrant arrhythmia.
Yeah.
Right. But what's odd is that the P wave appears to be before every QRS, and it's upright. It seems, at least in these two leads, which I think are exactly the same lead, that the axis of the P wave seems similar. Again, you can't tell in one lead of the EKG, but at least appears to be kind of similar axis. They're both upright, both in tachycardia and in sinus. So sinus tachycardia is a reasonable option for the differential. EAT, or ectopic atrial tachycardia, sometimes referred to as AET, is possibly the diagnosis here. The fact that the P wave is not inverted makes you feel a lot less comfortable about a diagnosis of ORT. So I think this is an example of how, even though EAT is an automatic arrhythmia, and presumably automatic arrhythmias should slowly warm up and cool down, this is an example of one that does not do that, that actually can be started with, looks like the patient has a PAC, and then tachycardia begins. Another possible differential in this could be sinoatrial nodal reentrant tachycardia, or SA node reentry, which is very, very rare. But in SA node reentry, there's reentry within the sinus node. And the way that one diagnoses this is to see a sudden onset and offset, and to look in a 12-lead EKG. And if the P wave morphology is exactly the same as sinus in all leads, then that would make that diagnosis. That's a very unusual diagnosis. I've only seen it once or twice in my career so far. Okay, so we now believe this patient has EAT. So how would you like to treat this, Uzoma?
Is this patient taking orally or?
Yes, patient's doing great, had a good switch, is very happy, is enjoying their Similac, but is not happy when she has tachycardia.
So if she's taking orally, we can do propranolol is an option for us.
Yeah, propranolol is reasonable. Any other options you could give? That would probably be my first choice, but there are multiple options.
Yeah, so propranolol is an option. Sotalol is an option.
Yeah.
Yeah, we have multiple options actually. Sotalol, we can
give
amio, we can do amio, but I just
right.
So what would your option be, Dr. Pass? Sotalol?
I think in this particular case, what we did was we started with propranolol. Actually, we started with digoxin, because when it first happened, the patient was actually not taking PO, and it was only happening very briefly for very short runs, like less than 10 seconds. And I just thought, why don't we go old school? And we did start, and it actually helped quite a bit, but the patient continued to have episodes, and as they got closer and closer to discharge, seemed to be having more of them. So then we went old school again and added propranolol to the digoxin. which is an old-fashioned approach, but I thought, why not give it a try? Very low toxicity profile of digoxin and propranolol. So we did that. And although that was helpful, patient continued to have tachycardia. And so finally, I decided to be an electrophysiologist and not a general cardiologist. And we tried sotalol, and that seemed to do the trick. So on a dose of about 100 milligrams per meter squared per day, divided Q8, this patient basically had no ectopic atrial tachycardia, had a few very short runs of 5 to 6 beats, but very rare, and the vast majority of the time was in sinus rhythm, had no further episodes such as this one, and so that is what the patient ended up on. And we, in the end, stopped the other agents.
So usually, Dr. Pass, I know when we talk about patients with ORT, we say usually if, we're going to do Zio monitors and all of that, and if they're doing fine with no breakthroughs, then we'll let them outgrow the dose, usually by year of age. Is that also the timeline we do for the EATs?
Yeah, I think so. I mean, the good news about this is, and those of you who've been on rounds with me, which is all of you, know that I've been saying for a long time now that for reasons that are not clear to me and others, there seems to be a very high number of postoperative patients, particularly babies, who are developing ectopic atrial tachycardia in the post-op period. And some of these are very challenging to control. Some of the hardest EATs I've encountered have been in post-op patients in the last 2 to 3 years. And this is fairly universal in the United States, and I'm not really sure why that is. But the good news about all of these is most of them seem to burn out on their own spontaneously. The younger you are with EAT in general, the more likely it is that the tachycardia will spontaneously end at some point. If you have this at, say, age 7, it is unlikely to spontaneously go away. But in a young infant, we would be very optimistic that this is going to go away. So what I would normally do is obtain a couple of intermittent monitors, like a Holter or a Zio or a Barty, something like that. And if there was very little or no tachycardia, then at about 6 months of age, if there was no tachycardia, I would usually at that point, my personal style is to start allowing the patient to outgrow their dose. Some would wait until 9 months, some to a year. Some might even stop it earlier, but there's no right answer to this, but that's my general approach. So, and with that, I think we will stop. Thank you very much for joining this morning, and I'll see you at Sign Out in just a short while, guys. Take care.
Thank you.
Yeah.
Thank you.